What does it take to exercise? Well, motivation, you have to have muscles at work, you have to have blood flow, and acceptable gas exchange. Overall concept of an exercise test is you'll put the patient on something, either a treadmill, a bicycle, even a cycle ergometer, and you'll just gradually increase the work rate until the patient can't go on. Along the way, you measure all the physiologic parameters that you can along the way, but paying particular attention at anaerobic threshold and at peak exercise. And you look and you compare what the patient did versus what you'd expect to have happen, and you really just try to figure out what limited the patient from exercising better than they did. So practically speaking, as I said, treadmill, stationary bike, increase the work rate, and cardiac measures that are monitored include heart rate, blood pressure, and EKG, as well as symptoms if they start clutching their chest, and then pulmonary parameters of oxygen consumption and CO2 production, tidal volume, respiratory rate, and then from these, a bunch of other things are calculated. So, starting from square one, time on the x-axis, gradually increasing work rate. I've drawn it here as a gradual increase, although it can be done in a stepwise increase. The technician will set the watts per minute increase based upon their gestalt of the patient. If the patient can barely walk into the room, they'll turn it up at a very low watts per minute. If somebody comes in who is wearing Adidas and like a marathon t-shirt, they'll turn it up more rapidly. An average person might do kind of 200 watts per minute at peak exertion. Like a good triathlon running person might be 350 or 400. The technician wants the test to last about 10 minutes. Why? In part because they don't want to be there forever. We're going to hand out there. But also in part because if the test isn't long enough, like it lasts just 90 seconds, there's no time to gather data. And if it were to go up at too slow a rate, the patient would never reach their limit until an hour or two went by, at which point they may be limited by other things, like their butt hurts on the bicycle, their arthritis kicks in, they're hungry, they're bored. So somewhere between 10 and 40 watts per minute is the general rate of increase. And at some point, the person can't exercise anymore, and that's their maximum VO2. So what I had on the previous slide was work rate versus time. On this slide, you can substitute VO2, oxygen consumption, versus time, because VO2 will go up linearly with time and work rate. The maximum is simply the maximum the patient attained. At rest, I hope people in this room know that an average person has a resting VO2 of about 4 mLs per kilogram per minute of ideal body weight. If I gain 100 pounds, that's not going to change. So we'll usually use kind of a rough number of maybe 250 or so cc's per minit at rest. Can you make sure it gets a handout? Thanks. And then it goes up dramatically with exercise, influenced by a lot of things. So if you were to pick up a journal of Men's Health or Runner's World, I'm sure there'll be at least one article talking about VO2, your VO2 max, and as though it's a parameter that is very relevant. And it is in some ways, but it's mainly genetically determined. If you want to be a good athlete, choose your parents wisely. With tremendous exercise, most people will only improve their VO2 max by 10%. Maybe somebody might increase theirs by 25%. But most people, even if they're a couch potato, with tremendous exercise can only increase their VO2 max by about 10%. And when it comes time, in about 30 minutes for us to at least look at an exercise test, the number one parameter that you start off looking at is the VO2 max. Because if the patient's measured VO2 max is at least 85% of what was predicted, they're normal. And you're done with the test. Which brings up one of the reasons for doing an exercise test. Let's say once every 2 or 3 years, I'll have a patient in clinic who's my age, so let's say in their 40s, but although that's a bit of a stretch, who never was as good an athlete as they think they were, but now it's 20 years since they were a good athlete, and they're like playing basketball with their kid and not keeping up like they used to. And they come in believing they now have a disease. Well, an exercise test can be a good way to show them that you're normal. You're just a little out of shape. Okay, so VO2 max, 85% or more of predicted is considered completely normal. This is a slide courtesy of Matt Hagwell, as I mentioned. So VO2 max, just to emphasize, is the most important parameter for ruling in fitness. If it's normal, it means you've got a combination of all these normal things and rules out, in effect, significant pulmonary, cardiovascular, or musculoskeletal disease. Now, I doubt any of us really like talking about the Fick equation, although occasionally people like Tobin and Fahey will mention it on rounds and expect you to have the equation. But remember, the Fick equation is a way of looking at the fact that oxygen consumption can be mathematically equated to cardiac output, so heart rate and stroke volume, times the difference between your arterial and venous oxygen content. So things that affect your heart rate would include your sinus node working and drugs. I've had 2 elderly ladies over the last 20 years that came in with dyspnea and exertion that I put through exercise tests, and their resting heart rate was 90, and at peak exertion it was 90. Okay, the reason they were short of breath is they could not augment their heart rate. They just needed a pacemaker. Stroke volume obviously can be influenced by all kinds of things. Your arterial oxygen content could be affected by anything lowering your saturation or your hemoglobin, so that brings in all of your lung diseases. And then your venous oxygen content could be affected by muscle disorders as well as peripheral vascular disease. And just to put things in a ballpark, your resting VO2, we said, is about 1/4 of a liter per minute. You can increase it a lot with peak exertion. Your heart rate doesn't go up quite as proportionally as much. Stroke volume resting is about 70 cc's, which you could have calculated, because you know your cardiac output is 5 liters per minute, 70 beats per minute, means your stroke volume must be about 70 cc's. And that can go up substantially. All of you people are too young to know Bjorn Borg, but apparently his stroke volume was like 4 liters, like with each beat. I'm exaggerating a little bit, but was a big stroke volume. And then our normal DaVO2, so the difference between arterial and venous content is 5 and goes up tremendously with exertion. Okay, so we talked about VO2. In addition to consuming oxygen, we produce CO2. CO2 rises linearly with oxygen consumption up to an anaerobic threshold. The ratio of CO2 production compared to oxygen consumption is your respiratory quotient. So depending on what fuel you're burning, that ratio could range from 0.7 to 1. 0.7 if you're burning pure fat, 0.1 if you're burning pure carbohydrate. Most of us Americans have about a 0.8 resting respiratory quotient apparently. Then at anaerobic threshold, the rate of CO2 production increases more than the rate of oxygen consumption does. Why is that?
So because you have bicarb, you're having lactic acid.
That's perfect. So we're going to go through that in the next slide. And this is important to the answer to. We have to go back to like energy substrate for metabolism. We have 2 substrates we burn routinely to generate ATP, fat and carbohydrate. Now, the good thing with fat is that we have tons of it. I mean, even the skinniest person in the room here is estimated to have 4,000 minutes of fat available for exercise. So unless you're really going to go out for a long run, you're not going to run out of fat. The problem with the fat is that to generate ATP from fat is slow, because you got to move the fat from here through lipolysis, through the bloodstream, across the membranes of the exercise muscle, and then go through phosphorylation. So it's slow, but unlimited. Carbohydrate can be found 3 places. One is as glycogen inside the exercising muscle cell. We all know that you do electron microscopy of a muscle cell and you'll see those black dots. So it's a very tiny amount of glycogen that's actually in your exercising muscle, enough to last a few minutes. Then our liver can make glucose, but our total stores there are only about an hour. So anything beyond that period of time, if you want to use carbohydrate, you have to keep on ingesting carbohydrate as you run or exercise. The good thing about it is that carbohydrate is a fast source of ATP because some of it is located right in the exercising muscle cell. Now, how are these things actually turned into ATP? Fat only has one way. It's through oxidative phosphorylation. So the typical free fatty acid, palmitoyl-CoA, apparently combines with 23 oxygen molecules to generate 16 CO2s, and hence you get that respiratory quotient is 16 to 23 or 0.7. So So for every 23 O2s you consume, you'll produce 16 CO2s. Carbohydrate also can be metabolized and used to generate ATP through oxidative phosphorylation. We know that one glucose with 6 carbons can be completely turned into 6 CO2s using 6 O2s, so a respiratory quotient of 1. But oxidative phosphorylation, be it a fat or carbohydrate, requires oxygen. If you don't have oxygen, you'd be screwed, except that you can still make ATP through anaerobic glycolysis or carbohydrate. But as everybody knows, that same glucose molecule that could have generated 36 ATP will now only generate 3. Really 2 from the glucose molecule. So obviously much less ATP per glucose. So how does anaerobic glycolysis lead to extra CO2 production since there's no CO2 being produced? It has to do with anaerobic metabolism, which by definition is producing ATP without any extra oxygen. So at the end of that last slide, we ended up with glucose turned into pyruvate. Well, that pyruvate is in equilibrium with lactate, which can then break down into CO2 and H2O, so we produce CO2 indirectly. So even though we didn't consume any more O2, we're producing CO2 indirectly, hence the disproportionate rise in CO2 at anaerobic threshold. So it allows you to keep exercising, but at a high cost of carbohydrate consumption. So any carbohydrate loading you did before the marathon, if you're running above your anaerobic threshold, you'll just consume it very rapidly. And you produce lactate, which then decreases your pH, your enzymes don't work well, and it becomes impossible at some point to even move your muscles. So anaerobic threshold, a lot of people have, I think, the misconception that anaerobic threshold is an on-off thing, that you're doing oxidative phosphorylation and then suddenly you do anaerobic threshold. But that's not true. You continue with oxidative phosphorylation, but at some point you're not able to deliver enough oxygen to the exercising muscles to generate all of your ATP oxidatively. So at that point, you continue doing what you can with the oxygen and oxidative phosphorylation, but for extra ATP, you have to do that anaerobically. And so measuring the anaerobic threshold is a second big thing we'll do in the exercise test, which you can do in several different ways. Directly measuring the lactate or indirect. Okay, so how do we do this? Back when I was a fellow, back in the day, we would put in an art line during an exercise test, and we would draw serial ABGs, and we would just plot out their bicarb. We usually just did bicarb until it went down, but you could do lactate where it went up, and so you can see a threshold where at a heart rate of about 150, this person hit their anaerobic threshold. Okay, so that's a very direct way. But we know we don't put in art lines for this, and so we do it predominantly indirectly through looking at gas exchange variables. And there's one technique that was developed maybe 10, 15 years ago called the modified V-slope method, which I'm not sure what the unmodified non-V-slope method is, but if you look at VO2 along the x-axis, VO2 consumption, and CO2 production on the y-axis, it's going up linearly for a period of time. And then it goes up linearly again, but at a different slope. And so this transition point, if you dropped a perpendicular down, would be where the anaerobic threshold is. So anaerobic threshold occurred at a VO2 of approximately 2.1 liters per minute in this particular example. Now, when you look at this in a real test, the dots are never in straight lines like this. They're kind of, spread around down here and spread around up here. So what's recommended is that you take the extremes. You go to the top and you take some sort of ruler on the graph and you draw a line approximating where you think, the line of best fit is all the way down, and do the same thing at the lower part all the way up, and where they intersect, you then drop a perpendicular, and that is your V-slope modified method way of identifying anaerobic threshold. And then you'll look at other parameters to see if the spot you picked was right or was an artifact. So here's a few other parameters that we haven't talked about, but we will now, and that you'd look at. So VeVO2. This will be referred to as the ventilatory equivalent for oxygen. Ventilatory equivalent for oxygen. In a second translation of English, that means how much you have to breathe to accomplish any amount of oxygen consumption. So VE is expired minute ventilation, so just your minute ventilation, divided by your oxygen consumption. At anaerobic threshold, you start breathing more because you breathe to keep up with the extra CO2 production. So VE goes up more than VO2 goes up, hence the ventilatory equivalent for oxygen goes up. Your end tidal O2. Since we're breathing more and not consuming any more oxygen, means we'll be left with more oxygen in our end tidal breaths, so the end tidal O2 would go up. And then the respiratory exchange ratio will go up because by definition that's VCO2 over VO2, and we're looking for the point where VCO2 starts to go up more than VO2. And eventually it'll go over 1. So we'll look at an example where all of these are tied together, but anybody who's looked at an exercise test, have you looked at one yet? How many? 2. So she's got 1/2 more than you have, Usman. You're not going to do many of them. And the reports come out, and the numbers are all over, and as I said, I just took my research exam, and the way a test or a different hospital is going to report their data is always going to be different than how we report our data. So it's important to know ahead of time what you're looking for. And so you'll look for the V-slope method, and then you'll look for these other parameters to see if they're changing at about the same time as you estimated the V-slope method anaerobic threshold. So all in one curve here, or one slide, the left upper there would be VCO2 versus VO2, using the modified V-slope method to drop the anaerobic threshold line down to find the VO2, at which point the rate of CO2 production started to exceed the rate of O2 consumption. Right next to that is VE versus VO2, so minute ventilation. Minute ventilation will go up parallel with oxygen consumption until you hit anaerobic threshold. Above anaerobic threshold, minute ventilation is going to go up at a disproportionate rate because we primarily breathe in response to CO2 production. And then the lower left one has the ventilatory equivalents for both O2 and CO2. So the lower left curve there, so we're looking at the lower left, and the lower curve of those two is the ventilatory equivalent for O2. So at anaerobic threshold, we'll start breathing more than the amount of oxygen we're consuming, so the ventilatory equivalent for O2 will go up. Notice, for a little while, the ventilatory equivalent for CO2, which is a second curve, stayed flat because minute ventilation is tracking with CO2 production. And then at this point, even the VECO2, the ventilatory equivalent for CO2, goes up, which is called the respiratory compensation point. At some point, we lose buffering ability. We produce so much lactate that we can't buffer anymore, and the pH starts to drop. So now we start breathing, not only to get rid of the CO2, but to compensate for it. So this latter point, which is a little bit further from anaerobic threshold, is the respiratory compensation point. At that point, minute ventilation goes up even disproportionate to CO2 production. I'm not 100% sure there's any clinical utility to identifying this respiratory compensation point, but it's talked about in all exercise discussions such as this. And then our end tidal O2 would go up at anaerobic threshold because we're breathing more than we're consuming oxygen, leaving more oxygen left behind in the expired gases. And meanwhile, at respiratory compensation point, the end tidal CO2 would go down because at that point we're breathing more even than CO2 production. So that may be the end of it's not the end of the theory. Anaerobic threshold, as I mentioned, is usually somewhere in the middle. if you're calculating this, it's very important to remember on an exercise test, everybody reaches a maximum VO2. Because at some point they stop. It might not have been a full of effort endeavor, but right now, if we stop the test right now, you'd be at your maximum VO2. So when you want to compare anaerobic threshold to truly maximum VO2, you compare it to the predicted maximum VO2. Because if you take an average couch potato, of which most of us probably qualify, and we stepped onto a cardio machine, as soon as we hit anaerobic threshold, we might stop exercising. That would also be our maximum VO2. So that would look like our anaerobic threshold was at 100% of our maximum, a highly trained athlete, which for most of us would not be true. Okay? And it varies a lot. So let's see, what do we have here? We have our time versus in gold, I guess, is the VO2 going up linearly. In green, the CO2 goes up linearly, parallel with oxygen consumption until anaerobic threshold, at which point CO2 production goes up at a faster rate. And then in blue is the minute ventilation, which is going up linearly with both of them until anaerobic threshold, then in parallel with CO2 production, and then at an even higher rate as it compensates for respiratory acidosis. I think that's what all this says. Okay. Now, MVV. What's the MVV? It's maximum voluntary ventilation. On every one of our PFT printouts, if you paid attention, in the spirometry section, it has vital capacity, FEV1, ratio, 2575, forced expiratory, forced whatever, Emily's number, and then it has MVV. So theoretically, you could have your patients sitting still do a voluntary maximum ventilation maneuver. So they would breathe into the tube as rapidly and deeply as they could for 15 seconds. Then you multiply it by 4 to calculate how much they could breathe during 1 minute at a maximum effort. We, of course, do it only for 15 seconds so they don't pass out. The calculated expected predicted values for an MVV are these. A normal person can do 35 times their FEV1. So everybody in this room would have an FEV1 somewhere around 4 liters per minute, which means you could breathe 140 liters per minute if you put your mind to it. Believe it or not, COPD patients are actually a little bit more efficient than we are, probably because they've gotten kind of used to it, and they can do 40 times their measured FEV1. So when we do an exercise test, people breathe obviously not in response to voluntary reasons, but they breathe what they need to breathe. And we will want to compare how much the person is breathing at their peak exercise compared to how much they could breathe if they put their mind to it. And to make sure we're all on the same wavelength here, what's to blame in normal people in terms of exercise limitation? The heart or the lungs? Diego?
Normal people.
Mm-hmm.
Into the lungs.
It's so disappointing. It's not our fault, it's the heart. Normal people at peak exercise could breathe even more, but we stop because our cardiovascular system isn't efficient enough through stroke volume or heart rate or capillary density or mitochondrial density to consume the oxygen being delivered to make ATP. So normal people are limited because of cardiac, can't say dysfunction, just the limits of cardiac capabilities. So if we measure a patient's exercise test and at peak exercise, they're breathing as much as they possibly could, that's abnormal. That means they're actually limited by their lung function. So let's do 2 more sentences in this to see if it makes sense. If you have a COPD patient whose FEV1 is 1.0 liter, their predicted maximum would be 40 liters per minute. At peak exercise, they'll probably be breathing 40 liters a minute, and the reason they stop is they just can't breathe anymore. On the other hand, take Erica with an FEV1 of 4. She would be predicted to be able to breathe 140 liters per minute, and at peak exercise, she's probably only going to be breathing 110 liters per minute, She could do 120, 130, 140, but she doesn't because she doesn't need to. The heart gives out before she reaches the limits of her breathing capacity. Okay, so VE is what you're actually doing. MVV is the maximum that you could do. So this ties into this next thing, the ventilatory reserve. So Diego, if I ask you a question, maybe the key is to look one slide ahead, and the answer may be on that one. So normally, exercise is limited by the cardiovascular system. Okay? Here's mathematically how much reserve we should have. And it's done two ways, different places. Either you ought to only use 70% of your maximum capability is one way of looking at it, that lower equation, or the absolute difference ought to be at least 15 liters between the maximum the person actually did versus the maximum predicted. So in order, as we're looking at our exercise test, we're going to look at VO2 max. If it's over 85%, we're normal. We're going to look at anaerobic threshold, just to see where that was along the way as a measurement of fitness more than anything else. And then we'll look at the ventilatory reserve. And if people don't have a normal reserve, then it's a mechanical lung problem. They have an FEV1 issue. In terms of breathing pattern, our tidal volume goes up first, and we don't even really notice it. Pay attention the next time you're on a treadmill and you're gradually turning it up. You can keep on talking with your friend, because you can kind of take a deeper breath, and it's kind of easy, but once you have to start breathing more rapidly, you recognize that. So tidal volume goes up first, then respiratory rate is illustrated in this slide, where minute ventilation goes up along the way, with respiratory rate being relatively stable for quite some time, but with a bigger tidal volume. What's the implication regarding dead space that you could draw from this curve here? Because we're going to look at dead space in a minute. So you could probably look one or two slides ahead. But dead space is wasted ventilation, which is anatomic, our trachea and main bronchi. Well, that dead space volume isn't going to get bigger with exercise, but our tidal volume is getting bigger, so the proportion of dead space to tidal volume is going to go down because our tidal volume goes up by so much. And I think this is just kind of interesting. People in this room know this, that normal people, we have a normal FRC compared to COPD, who they have a high FRC because they've lost elastic recoil of the lungs, so their FRC is higher. But it even gets worse with exercise. With exercise, they don't have time to exhale that last volume because they have flow limitation, and they get progressive breath stacking, contributing to their increased work of breathing. It's hard to breathe when you're at a high lung volume. In terms of the dead space, everybody should know that a normal person has roughly a third of their tidal volume is wasted dead space, and it decreases with exertion because our tidal volume goes up. In terms of oxygen, normal people do not desaturate with exertion. Okay? People with normal lungs do not desaturate with exertion. Yes, on Monday Night Football, a 350-pound lineman will run a play that lasts approximately 5 seconds and will then run to the sideline and put on an oxygen face mask. If a 350-pound lineman wants an oxygen face mask, I'm going to let him have it. But he doesn't desaturate. Okay, so normal people don't desaturate, even though our AA gradient goes up slightly. Enough on the lungs. We'll buzz through the heart stuff. Heart rate goes up linearly. Yeah. Then there's this heart rate response, which is a complicated mathematical thing that is a fairly big part of our exercise test interpretation. So heart rate response, in effect, is saying, how many extra heartbeats do I need to accomplish X amount of extra oxygen consumption? Because to consume oxygen, you got to deliver the oxygen. How many heartbeats does it take for me to get this next aliquot of oxygen to the tissues? So the way you do it mathematically is you look at the resting heart rate and the maximum heart rate, subtract those, divided by the resting and the maximum oxygen consumptions. And normally, it ends up that this ratio is about 40. I guess that means that we would have, on average, 40 extra heartbeats to accomplish 1 liter more oxygen consumption. Okay? In a highly fit person, you may only need 25 extra heartbeats to accomplish that extra oxygen consumption because each heartbeat is delivering a bigger stroke volume to the tissues. And if you're deconditioned, each heartbeat only has a little bit of extra stroke volume, and so it would take more of them to accomplish the same oxygen consumption. Does that make a modicum of sense? Then there's this thing called the O2 pulse, which is a poor man's way of estimating the stroke volume. And mathematically, you can see how this is. It's just basically taking the VO2 at any given moment divided by their heart rate, and it gives you an estimate proportionally of what the stroke volume would be, not in cc's, but just in an absolute unit. And at peak exercise, these are the normal values. So if we're doing an exercise test and people don't reach those peak values, it could be that they just stopped trying. But if they don't reach those peak values and it plateaus, it means they're trying and they can't do any better than that. It implies a cardiomyopathy, of which deconditioning is a mild example of a cardiomyopathy. Cardiac output goes up from 5 to the 20s. Blood pressure, I know this is not immediately intuitive to people. If blood pressure goes down during an exercise test, it's a sign that the patient is dying and you need to stop the exercise test. We know that long-term exercise leads to lower blood pressure, but while exercising, our blood pressure goes up. So just putting the heart stuff together, as VO2 goes up, our heart rate goes up linearly, cardiac output goes up, both stroke volume and heart rate. And to be honest, I'm not exactly sure what I'm supposed to take away from this slide, but it's all on one graph. So then you get to pattern recognition. And just overall, in general, people who have cardiac problems will use the term fatigue. And anybody who's interpreted an exercise test knows that the first line in the standardized form says the patient exercised for X minutes and stopped because of blank. And on average, cardiac patients will just say fatigue, tired, I just can't do it anymore. Whereas lung patients tend to say shortness of breath. And of course, acute ischemic people will say because of chest pain, and peripheral vascular people because of leg pain. Cardiac folks have a low anaerobic threshold. You know, they can't augment their cardiac output, so they can't deliver oxygen to the periphery. They become anaerobic early on. Pulmonary disease patients usually stop right at the moment they're hitting anaerobic to where it makes it impossible to even identify it. Lung patients may desaturate, others should not. And then there are the cardiac parameters and the pulmonary parameters, which would indicate disease within those areas. Stepwise interpretation. We already mentioned this like 14 times. VO2 max over 85% is normal. If it's lower, then you look for these patterns. So pulmonary patients can have a low ventilatory reserve, a high VEV CO2. If you think about that, it's ventilatory equivalent for CO2. If you've got to breathe a lot more than average to get rid of the same amount of CO2, that implies some gas exchange abnormality. In dead space, if it's high and or doesn't drop, that's a pulmonary vascular problem. And then cardiac things, low anaerobic threshold, a high heart rate response indicating they're not augmenting their stroke volume well, and a low O2 pulse, another way of looking at stroke volume. So a couple of slides on like when we're supposed to consider doing these things, and then one more algorithm of how to go through it, and then questions if you have any. So this was my slide, and when I ordered them, and then the next slide is what the guidelines actually say. So I've ordered them through the years to prove to somebody that they're normal. Okay, you're normal. You're just not 20 years old any longer. Patients don't like to be told they're not 20 years old any longer, even though it's pretty apparent that they're not. So you can do an exercise test. I've also had some people that were extremely fit, but they're just not making the times they did in their 10Ks 2 years ago, and they're sure they have like leukemia or something as an explanation. And in those cases, to prove somebody's normal or even extra fit, to put them through a test and show them these reams of data can psychologically help the patient come to grips with the fact that they just should have chosen better parents. Deconditioning. No one likes to be told they're deconditioned. Let's face it. And that's the cause of shortness of dyspnea on exertion in probably half the patients I see in clinic. And, so how many CTs and PEs and echoes and pulmonary hypertension workups are you supposed to do in these people? Theoretically, you could do an exercise test to show, you're just not quite in tip-top shape any longer. And then it can be used to help sort out cardiac versus lung. Someone's got some emphysema, they've also got some heart disease, but which one is the biggest issue? A cardiopulmonary test can help sort that out. This last thing, in a couple of weeks, you're going to have a discussion on lung cancer, which for the first time in over a decade is going to be delivered by somebody other than me. I think it's going to be Brian Canavan, since he's now going to the Tuesday conference. But when it comes to lung resection for lung cancer, we all know you have to have adequate pulmonary reserve in order to survive having lung resection. And we estimate that predominantly through FEV1. But in borderline cases, we will do an exercise test. And there are good data that say if you can't reach these values, like the VO2 as measured at your anaerobic threshold, if it doesn't hit 11 cc's per minute per kilogram, your mortality is dramatically higher than if you do hit that value. And apparently back in the day, all thoracic surgeons had their offices on the second floor of a building, so that if patients could at least walk up one flight to their office, they were probably hitting something like this anaerobic threshold value, and that meant they could survive. Now, they just have to pass through billing to make sure their insurance is adequate before they get their lung resection. So this is going to be probably impossible to read, but there is a reference in 2003 from the Blue Journal of what are the supposed indications. And the things that this Matt Hagel guy, that good friend of mine, and he's out of Utah, which is a big pulmonary function, mecca place, and he's written a number of articles on this stuff. And he happened to be in town this weekend, so I stole some of his slides. His red highlighted ones were to just determine exercise limiting factors and pathophysiologic, whatever that says, mechanisms. Okay, so to figure things out. Then there's symptoms disproportionate to the objective data. They got a little bit of an FEV1 problem, but not disabling shortness of breath. This might be helpful. Unexplained dyspnea, when other tests are non-diagnostic, okay, so a workup for dyspnea. Functional evaluation for patients with heart failure. I'm not exactly sure on the data behind this, but you've probably seen that almost all heart transplant people go through an exercise test to measure their METs ahead of time. Selection for cardiac transplantation, and then lung resection surgery were things that he had highlighted. And then this is a little bit easier, an adaptation from the ATS-ACCP statement on CPET. So indicated, evidence-based assessment, evaluation of exercise capacity, and response to therapy in patients with heart failure for heart transplantation. So there presumably must be good data for that. Assistance and differentiation from heart versus lungs. Okay? And then some supportive evidence. Other data are unreliable. I guess that's reasonable. Person can't seal their lip on the spirometer or other problems. And then weak supportive evidence to follow therapy, or to, like all those commercials say, see your doctor before embarking upon an exercise regimen. I'm not exactly sure what I'm supposed to do when those patients come in and tell me that, but maybe this is one of those things. So this graph kind of puts it all together, and if one wanted to, there are two great resources for exercise physiology stuff. One is a textbook called by an author named Wasserman. He was originally at Ohio State, and now I think UCSD, and it's not worth going out and buying when you need to be reading more basic stuff early in fellowship. But it's an interesting text. I'm sure we have it here. I have it in my office. It's in the library. But Wasserman is he's like Bono in the realm of cardiopulmonary exercise testing. And then the other is a book called The Lore of Running, which is just a book you would get at Borders, or Borders is closed, right? So, online, wherever you, Amazon. The Lore of Running by Timothy Novak, who's a physician from South Africa, a long-distance runner. And in South Africa, they have a race called, I can't remember what it's called, but it's the Cape Town Marathon. But it's 56 miles. So he's really quite a runner, and an exercise physiologist PhD. So this book of his is written for lay people, and the first half of it is just really interesting. Like, if you want to run at altitude, what you should do to prepare yourself for it. Should you wear like a bodysuit to cut down on friction, which would save an average marathon runner 4 minutes in a race, but you'd likely die of heat prostration. So it's an interesting book, and this is where I got all this stuff. And so you could Google a curve like this, which will just show you all the things that we talked about individually. And then just a couple more slides. Starting at peak VO2, if it's normal, you really aren't going to find a disease as an explanation. If it's low, the next thing is anaerobic threshold. If you have a normal anaerobic threshold, then it's probably not a heart thing most of the time. And you're going to look to the breathing reserve to see if it's a mechanical thing, as in a ventilatory impairment, and so on in the algorithm. So let's take one step at a time. Things that the TAC will probably report if the patient didn't give a maximum effort are obviously important, because if the patient didn't try, then all of our numbers are going to be low. And these are a variety of the different things. The number one thing is not reaching an adequate heart rate. Then is VO2 normal, anaerobic threshold, and we want the anaerobic threshold to be at least 40% of the predicted. It's not formatted very well. And then cardiovascular pattern. I think I'm fully into the range of repeating myself. Ventilatory response and gas exchange, and some patterns. So I discovered this right before I came over. This curve is going to mean absolutely nothing to you because it doesn't have the coexistent second page to it. There's a great article from Chest from about 15 years ago in Exercise Interpretation that has this curve that says you start with, VO2 max. And if it's low, then you do the ventilatory reserve. Depending if it's low or high, then you do the ventilatory equivalence. And then for each of those, you could desaturate or not. And then the cardiac parameters. And for each of these letters down here, in the second sheet, it tells you that like Q correlates with, this combination of abnormalities. But you could figure it out at this point in time. And then finally, I'm not exactly sure if this is what's in the computer as our standardized test interpretation. Back when we did them in hand or in paper, this is something I created a number of years ago, which starts with the patient exercised for X minutes and stopped secondary to whatever. The next step, the maximum VO2 was X of what, giving a percent predicted. Ventilatory reserve, which if it's normal, is normal. If it's significantly low, it implies ventilatory limitation to exercise. Then it's ventilatory equivalent, oxygen saturation, heart rate response, and the anaerobic threshold. And maybe I was smart enough that these letters here correlated, but I don't think I was. But this is our basic interpretation form. So